I wish that I could take credit for this title or interesting title, but it's not mine. It's actually from it's actually from an editorial that was written by Burge Griggs and Tony Amato back in 2004, 2003, in response to an article that came out of the Dutch group about polymyositis. And it's been interesting to follow this literature, but also the personal experience that I've had with polymyositis. So this is the outline that I'm going to follow. I'm going to talk about the classification, the current classification of our inflammatory myopathies, especially the Bohan and Peter criteria, which is still the most prevalent and dominant criteria used by rheumatology, dermatology, as well as a number of the clinical trials in this disease are done using this criteria. And what I'll then do is to show you a few cases, real cases, to show how inadequate this classification is, and then talk about the literature of how rare polymyositis is. So back in 1975, when Bohan and Peter published their criteria, life was much simpler. You only had two main primary inflammatory myopathies. It was either polymyositis or it was dermatomyositis, and things were much simpler. Back then in about 1978, the concept, or at least the entity of inclusion body myositis, was firmly established as a separate entity, where there was prominent inflammation of the disease of the muscle, but you also had rimmed vacuoles, you had amyloid, and very early, even in 1978, folks recognized that this particular entity does not respond to treatment, and this may be different from polymyositis. And as early as 1986, Mike Brook, in his last edition of his book, actually talked about whether he even thinks this is a primary inflammatory muscle disease as well. I still believe in the inflammatory component, and I'll show you some data why I think that's important. And then about 1994, the concept of necrotizing autoimmune myopathies came about, and by 2003, it was firmly established as the fourth entity in this class. And now, just in the last few years, there is a fifth one, which is anti-synthetase antibodies, and I won't talk much about that right now, which is the collection of these muscle diseases with very specific antibodies to the tRNA synthetase, and there are now about 8 of those tRNA synthetase that cause muscle disease. Now, we are always known about the overlap myositis, which turns out to be quite common. So these are patients with lupus, Sjogren's, scleroderma, who also happen to have an inflammatory myopathy. And then we've always known about sarcoid and granulomatous myositis as a separate entity. But there are other diseases like eosinophilic syndromes and myositis caused by infectious agents. I just came back from Singapore, where I attended the Asian Oceanic Myology Conference. And a number of cases of muscle parasites were presented there, which we don't see a lot of it here, but at least in Asia and tropical countries, you see a lot of parasitic infections as well. So this is the famous Bohan and Peter criteria, and if you guys have not read the original review article, I would strongly encourage you. It's a beautiful piece of work. Bohan still practices rheumatology. He was in faculty at UCLA, as was Peter. And he laid out 4 main elements to this criteria. One, you had to have symmetrical weakness of limb girdle muscles. Anterior neck flexor can be involved. You can have involvement of respiratory and swallowing muscles. You have to have muscle biopsy evidence of necrosis, as well as regeneration. And you also have to have evidence for inflammation of myophagocytosis. You had to have elevation of serum transaminases or CK or aldolase, and you had to have electromyographic evidence for what we would classically call as a myopathic potential, which is short duration polyphasic units with early recruitment, and irritability, which is fibrillations and positive shock waves. Now, to make a diagnosis of definite polymyositis, you had to have all 4 of these. To make a diagnosis of dermato, you had to have 3 or 4 of these with a skin rash. And then probable is slightly less, and possible is the lowest probability in that sense, where you only need one criteria plus rash for DM and two criteria without the rash for polymyositis. So the first argument that I'm going to put you is that if Bohen and Peter criteria is really still adequate in the modern day to classify inflammatory myopathies. And I'm going to start off with this first case. So Allison was a patient of mine. She's now actually doing very, very well. She had just started as a junior professor at Claremont McKenna. And about 2 months, she had about a 2-month history of joint pains, especially wrist. She had progressive proximal muscle weakness for about 6 months. She did not report any skin rash. I specifically asked about skin rash, and she said no skin rash. And she had one of the most troubling symptoms for her was very significant aching of the muscles. So her exam showed no malar rash, no Gottron papules, none of the rash that you would expect from dermatomyositis. She had a grade 3 strength in the proximal muscles. She had grade 5 strengths in the distal muscles, and her hip flexors were about 4+. Her deep tendon reflexes were normal. Her strength and sensory examination was normal. And her laboratory panel, other than a positive ANA, and I can every third person at our lab seems to have positive ANA, so I am not a big believer in ANA in isolation. But she had a positive ANA. Her CK was normal. Our upper limit of the normal for our lab is 240. So 219 is very well within normal limits. Her CBC and chemistry panel was normal. And her EMG clearly showed a fairly significant, very severe irritable myopathy. So no doubt that we are dealing with a muscle disease. So if you had applied the Bohen and Peter criteria, she would have met the criteria for probable for plus rash for DM, although she doesn't have rash, but she definitely would have met the criteria for probable polymyositis. She has proximal muscle weakness, she has irritable EMG, and she, as you would see, she had inflammatory infiltrate on the muscle biopsy on that. So at this point, if you were taking care of her, what would you have done? I did give you the answer to some extent. I did the muscle biopsy, but a lot of people don't do muscle biopsies, and especially if she was in rheumatology track, a lot of the times they would have done MRI, or not even doing an MRI. They would have gone straight to treatment at this point. So we ended up doing a muscle biopsy in her, and this is her muscle biopsy. Oh, this is interesting. So this is the muscle biopsy, and you can see there is an area of inflammation, lymphocytic infiltration that is predominantly in the perimysium. It's surrounding a blood vessel, and it's pretty much restricted to the perimysium. There's no inflammation within the endomysium as such. And then if you look at the connective tissue out here, the connective tissue seems to be disrupted. This is what we call rarefication or fragmentation of the connective tissue. And it's, again, restricted purely to perimysium. And if you really squint, and actually you don't have to squint a lot, you see that a lot of the muscle pathology is actually in the perifascicular area. And this is probably the most characteristic biopsy features that you would see in dermatomyositis. You have lymphocytic infiltration in the perimysium, it's perivascular, you have fragmentation of connective tissue, you have perifascicular atrophy. This is pathologically dermatomyositis. Even if the patient doesn't have a skin rash, this is dermatomyositis per se. So our muscle biopsy was diagnostic of dermatomyositis, and then we sent off the myositis panel, and her antibody came back positive for MI2, which is one of the dermato-specific antibodies on that. So again, it sort of closes the loop. It tells you that we are dealing with dermatomyositis, even though she doesn't have a skin rash. And the challenge is that I think we being, and especially rheumatology, is being very restrictive with their diagnosis of dermatomyositis. A lack of skin rash does not rule out dermatomyositis. About 6% of dermato patients may not have a skin rash. And even the bigger problem is that what we consider as a dermato skin rash is not specific to dermato. It turns out that the only specific dermato rash is the heliotrope around the eyelids. The mechanics hand, the Gottron's papules, you can see them in other diseases as well. They may not be specific to dermato. So that's part of the challenge as well. Periphysecular atrophy is diagnostic for DM, but it may not be present in each case. So your muscle biopsy can be negative. Oftentimes, the muscle biopsy will show you perivascular and perimysial inflammation, but then it gets, because you don't have the periphysecular atrophy, you don't have some of the other changes, you call it as non-specific myositis. And as I said, the heliotrope is the most specific. The other problem is CK may not be elevated. This is one of the few inflammatory myopathies where CK can be completely normal. Okay, even though, as you saw in this case, there was a fair amount of inflammation, there was irritable EMG, her CK was still normal. And so pathology in dermatomyositis is actually fairly interesting and fairly typical. So you see the periphysecular atrophy on an ATPase stain. If you use a stain for embryonic or fetal myosin, you can actually see the regenerating fibers in a periphysecular distribution here on that. And if you do oxidative stains, you actually see lack of oxidative staining in the periphysecular region, which had led to this notion that this is an ischemic change per se. And then if you use alkaline phosphatase, you can actually highlight not only the regenerating fibers, but you actually see the intramuscular capillaries as well. So the real pathology in dermatomyositis is a dropout of muscle capillaries. So this is a normal muscle with all these dots representing a capillary. And if you see dermato, you have an overall decrease in the capillaries, but the existing blood capillaries actually become larger in response. And if you do staining for complement pathways or the complement cascade, especially the terminal portions of the complement cascade, you will see positive reaction. So this in dermatomyositis, there is complement deposition on the blood vessels that led to the hypothesis that you have an immune-mediated destruction of the blood vessels, and therefore you have ischemia, and that's why you have pathology. And the region of the muscle that's most affected by ischemia is the periphysecular region, and therefore this has to be an ischemic. It turns out all of this is now related to interferon expression. There is a upregulation of interferon expression, which will do all of this pathology. And there's some beautiful work coming out that shows that this is all interferon-mediated disease. Dermatomyositis is a B-cell disease. So this is a stain for CD4, which is lymphocyte. And this is a stain for CD20, which is B cells. And there's very prominent B-cell involvement in this disease. And then there's a very recent paper from Nishino in Japan, which talked about this myxoma resistance antigen, which is one of the pathway, which is in the interferon pathway. And it turns out that if you use staining for the MXA, you have a far higher sensitivity to diagnose and specificity to diagnose dermato. This is even better than periphysecular atrophy. This is even better than using some of the other stains. So what he's recommending is that we should routinely use MXA as a stain to diagnose polymyositis. And then there has been an explosion in myositis-specific antibodies. So the first antibody that was described was the Mi2 antibody back in 1976 by Maurice Reichlen. And this is what Allison has. But over the years, then you had Jo1 described, PL7, PL12. And just in the last 10 years, you've had at least 10 new antibodies that have come out. And what I'm going to do is I'm going to make life easy. These are the 5 antibodies in dermato. These are very specific to dermato. You don't have to worry about the rest of them right now. Mi2, which is what Allison had, is a good antibody. When you have a Mi2 antibody, you get a very classical inflammatory dermatomyositis response to treatment. The risk of malignancy is low, although that's being disputed very, very recently by the French group. And they tend to have very high CK. The two that I would specifically mention are the TIF1 gamma. And if somebody has dermato and if they have TIF1 gamma antibody, which is the last one, they are at incredibly high risk for malignancy. These patients usually present within a year with a malignancy. So it's a paraneoplastic syndrome. They also have very atypical skin rash. They usually get necrotic, ulcerating skin lesions. It doesn't look very much like dermato. And then the MDA5 is predominantly an Asian disease. It was reported in Japan, and even in the US, you predominantly see it in the Asian populations. it's an interesting disease because you have very minimal muscle involvement. You have predominantly skin involvement in MDA5. The skin involvement can be ugly looking, but the other association is incredibly high rates of interstitial lung disease. And you have to monitor them for development of interstitial lung disease on that. And NXP2, it just predicts that they're going to have calcinosis. So that's another useful thing to remember about MXP2. That. The other pet peeve of mine is and I'm sure Michael gets this as well, we get a lot of referrals from rheumatology and other folks where they want us to tell them whether the EMG shows a inflammatory myopathy versus muscular dystrophy versus any other muscle disease. And the reality is we're not that sophisticated. All we can tell you is that there is muscle disease, there is irritable muscle disease, and irritable is a catchphrase which suggests that if you do a biopsy, you're going to see necrosis, but nothing more than that. We cannot tell you whether this is polymyositis versus dermato versus muscular dystrophy as well. And the muscle biopsy still remains very important. We are using a lot more muscle MRI. It's interesting, every time I order a muscle MRI, I have to field 3 phone calls with insurance companies and just try to justify why MRI needs to be done and make deals with them on that. And then the muscle specific or muscles associated antibodies have become very important, not only in establishing a diagnosis, but also in terms of prognosis. And that's why we use a lot of it. So I'm going to switch to the second case. This is, again, another case. This is Wendy. And Wendy presented to me about 10 years ago. And at that time, when she first came to see me, she had a symmetric muscle weakness of the upper and lower extremity. Her history dated back about a year. She denied any dysphagia. She had no skin lesions. She had no pain, no family history. And she was on prednisone of 20 milligrams. And she came to me with a prior muscle biopsy that showed a T-cell inflammatory disease in the muscle. Her workup, her CK was 370, which is marginally high. As I said, her muscle biopsy had shown a T-cell inflammatory disease. She had an ANA of 300. Her examination showed symmetric proximal weakness, but she also had some distal muscle weakness. She had deltoid strength of 4. She had hip flexor strength of 4. But her finger flexors were also involved, which was 4+. But she had symmetric weakness. There's no doubt that she had symmetric weakness, and may have been some response to initial steroid treatment on her. So when we did a forced vital capacity, she had slight evidence for diaphragmatic insufficiency. I mean, we normally like to see the forced vital capacity not changing when you go from erect to supine, but hers changed about 10%. Her myositis panel was negative at that time. Her EMG again showed a irritable myopathy. She had profuse fibrillations, small amplitude potentials. And even though she'd been on steroid treatment for about 3 months, she reported no benefit from it. And so we asked her to taper her prednisone. I was unhappy. I said, we'll do a biopsy again. So we took her off her immunosuppression. We biopsied her again. And this is what the biopsy showed. Her biopsy showed again, an endomysial inflammation. So unlike the other patient, this is now within the muscle fascicle, and it's surrounding a muscle fiber. And you can actually see that some of these inflammatory cells have actually broken through and invaded the muscle fiber out here. So this is a fairly classical endomysial inflammation. This is an abnormal muscle fiber, and this may be an early ragged fiber, which is usually suggestive of some mitochondrial abnormality, but that was the only one that she had. So she meets the definite criteria for Bohan and Peter. She has proximal weakness, she has high CK, she has an irritable EMG, and she has a muscle biopsy that shows an inflammation on that. And so what do we do at this point? Okay. And this is a challenging question because you can give multiple answers. I probably would have treated her further with IVIG or something. I would have done some special stains on her thing. I would have done an MRI. And what we did, we asked our pathologists to do some special stains. And these are mitochondrial stains, because remember I showed you a little bit of a ragged fiber. So normally in a cytochrome oxidase, you should only get two fiber types. You have type 1, which is rich in mitochondria, and you have type 2, which is more glycogen but less rich in mitochondria. But there is a third fiber type out here. There are fiber types with no staining. Okay, so you have one here, you have one here, you have one here, you have one here. And this, so again, the incidence of mitochondrial deletion increases with age. So one argument could be that she's older and that's why she has more mitochondrial abnormalities. She's only 53. I hope that my muscle, and I'm 52, my muscle doesn't show this. Okay, so this is abnormal, and this is again a little bit of a clue. So this is something that Alan Prestrong called as polymyositis with COX-negative fibers back in 1995. And the suggestion was that this is a form of polymyositis, but they become treatment resistant, and you have to treat them with methotrexate. So we treated her with IVIG and we treated her with methotrexate. And there was some initial increase in strength, but she continued to decline. And over the next few years, she developed asymmetric muscle weakness. She had very prominent finger flexor weakness. She had very prominent quadriceps weakness. And when the new antibody for IBM came out commercially, we tested her and she was positive for the anti-5C1A antibodies. And what she has is not polymyositis, but she has sporadic inclusion body myositis, which is the commonest acquired myopathy in adults. It can present in about 6% of subjects with symmetric muscle weakness at the onset, especially in women, and I'll show you some data why that's true. This bulbar dysfunction is very common, and she did develop very prominent dysphagia later on, but it may not be present early in the disease, and especially in women. Respiratory insufficiency is underappreciated in this disease, but happens. And this disease, despite our best efforts for treating it, has been treatment unresponsive. Okay, and they has not responded to any of the known treatments at this stage. The problem with IBM is muscle biopsy may not show vacuoles, okay, which is the traditional pathognomonic sign in IBM. So pathologists want to see rimmed vacuoles, but very early in the disease, especially in women, rimmed vacuoles may not be present. The earliest sign of abnormality may be just inflammation on that. And then the mitochondrial staining adds value. It actually is very common. And actually, if you see somebody with an inflammatory myopathy with a lot of cytochrome oxidase negative fibers, think of IBM. And we used to treat these patients. Till about 2010, I was treating these patients, especially the early ones, with IVIG. And I stopped doing that in 2010 based on this paper from the combined experience of the Paris group and the Oxford group that suggested that patients who were treated with immunosuppressive agents with IBM in the long run did worse. They had worse disability, they had more need for adaptive devices, etc. Okay. Now there are a lot of problems with this paper. This has been criticized over and over again. It's a retrospective review, but it really leads it at least invokes this possibility that maybe we're doing our patients more harm, and some of that inflammation may actually be a protective inflammation in these patients. That two separate groups described the anti-5C1A antibody in 2013. The sensitivity depends on what article you read and where the article was published. Ranges anywhere from 60 to 70%. Some of the more recent one actually says 35%. What's good about this antibody is that the specificity is incredibly high. If you have the antibody and if you have muscle weakness, you pretty much have IBM. Okay, and we've now recent off rate picked up very, very early cases with very minimal weakness, or they have one guy with hypercemia with this antibody recently. So this is what the original paper looked like. This is Steve Greenberg's work. And what Steve did was he ran a dot plot on his patients with IBM and PM. And you can see that a lot of their IBM patients had these abnormal dot plot, but only few of the PM patients had that. So when you compare your IBM patients to all other diseases, there was clearly a much higher incidence of the antibody, but again, depends on where you put the cutoff. So if you put the cutoff at 10, then you reduce your sensitivity, but you increase your specificity. But if you're a little liberal with your cutoff at 2.5, then you increase your sensitivity, but you reduce your specificity. So most of the labs now are using anywhere from 2.5 to 5 standard deviation as a cutoff for this thing. He also did laser microdissection of the vacuoles and then stained them, and it turns out that they're all staining for this antibody as well. And then this has actually been looked at by other groups. So this is the large European group, which used a antibody to 3 different regions of the protein, and they again showed the same thing. You have very high incidence of this antibody in IBM, but there is also a smaller group of Sjogren's patients as well as lupus patients who tend to have this antibody as well. And then the Hopkins group also had a similar data that about 14% of their lupus patient and about 23% of their Sjogren's patient had this antibody. The important thing to remember is that none of these Sjogren's patients and none of these lupus patients had any detectable muscle weakness. And that's why I made the statement that if you have a patient with muscle weakness, and if you have a positive antibody, you're probably dealing with IBM. The other problem with IBM, and Steve Greenberg showed that in his first paper, but we also recently had a case, the antibody may exist 10 to 15 years prior to their onset of diagnosis, or their diagnosis. We recently diagnosed a patient who I have been seeing since 2003, presented with proximal muscle weakness. I've shown him to multiple experts. Everyone thought he had type 4 SMA because he had such symmetric proximal muscle weakness. He had seen Alan Prestrong back in 2003. Alan had serum saved on him. He recently developed asymmetry, finger flexor weakness. We tested him for antibody. He was positive. Alan went back and looked at his sample from 2003. He was strongly positive back then. Okay, so this antibody may exist 15 to 20 years prior to their diagnosis. So all of these, and we know that there is a higher association with Sjogren's with IBM. So maybe these patients with Sjogren's who have the antibody are just pre-symptomatic or asymptomatic IBM patients that are going to manifest at some point later in their lives on that. And then we, about 2 years ago, published this paper. We were the first group to show that if you have the antibody to the anti-5C1A antibody, you tend to have more severe motor phenotype. And in this paper, we showed that the time get-up, which is a very good test of proximal hip girdle strength, was significantly abnormal in patients who were seropositive. The forced vital capacity was lower. The patients with antibodies invariably required either a walker or a wheelchair. Patients who were seronegative, none of them needed a walker or a wheelchair. And then the bulbar dysfunction was significantly higher in the patients who were antibody positive. Subsequent to this, other groups have looked at this. This is the large 300-patient study from Europe, which confirmed our findings, which showed that patients who have antibody positive IBM had a higher adjusted mortality risk. They actually live about 8 years less than the seronegative patients. They have a lower frequency of proximal muscle weakness in the upper limbs, and there is an increased prevalence of cytochrome oxidase negative fibers on muscle biopsy, as well as more facial weakness. So there are pathological differences that are coming out as well in terms of whether you're seropositive or seronegative. Seropositive patients tend to have more cytochrome oxidase negative. Seronegative patients tend to have more rimmed vacuoles as well. This is, as I say that this is actually an incredible paper. This is the Japanese group, and what they did was that they took blood from patients who were seropositive versus seronegative IBM, and they did 2 things with it. They actually, 1, put it on myoblast cultures, and number 2, they passed it on to rats and mice and see what happens to these animals. So in the myoblast cultures, what they showed was that when you put the serum from seropositive patient, you get these myoblast fibers will start expressing these P62 vacuoles, P62 positive vacuoles. P62 is a marker of autophagy. So they showed that when you put serum in there, you get very abnormal vacuolation. But if you put serum from seronegative patient, nothing happens to these muscles. And then the next, this is just a graphic representation of it. But they also showed that patients who were positive, human patients who are seropositive, have much more severe muscle atrophy compared to who are seronegative. And again, this is just findings in their muscle. So you have antibody staining, you have P62 staining in the seropositive, but very little or no staining in the seronegative patient. So this is the first proof that the antibody is actually doing something, okay, different. There are pathophysiological differences on that. So there may be different pathways that is happening in the seropositive versus seronegative. And I'm going to go to my last case, which is somebody that I saw in April. And this guy apparently was completely normal till Christmas time. He was going through a fairly nasty divorce. This is a guy who, for exercise, used to run up the stairs in a football stadium. That was his daily exercise. He would go up the stairs, come down, go up again. So extremely fit guy. But within a period of 3 months, had very rapid progressive weakness. When he came to see me, he couldn't talk. He had severe nasal weakness. He couldn't eat. Severe dysphagia. He had lost a lot of weight. He could not hold his neck up. So he actually was sent to me with a diagnosis of ALS. And it was such a rapid progression that I said, nah, this is not ALS. This is something else going on. So I put him straight into the hospital from the clinic. This guy went straight to the hospital for a G-tube, but also for a muscle biopsy at that time. But as I said, all of his symptoms started about 3 months prior to this. He does not take any medications. He was not taking any known muscle toxic or anything like that. His exam showed nasal speech, reduced gag, neck flexor weakness, upper extremity was 4-, lower extremity was 3, the quadriceps was 4+, his DTRs were 1+, no skin rash. His lung capacity, surprisingly, was normal. His CK was only 500. His EMG showed a chronic myopathy with some acute changes. We test routinely for Pompe disease, which is a treatable muscle disease, and his Pompe testing was negative. And now I've done 2 separate, 5 years apart, 2 separate antibody panels on him, and he's been negative every single time, including some of the newer fancy antibodies. But if you run the Bohan and Peter criteria on him, he meets the definite diagnosis on there. So again, at this point, the diagnosis would have been polymyositis because you have no other features on him, and he got admitted to the hospital. And this is what his muscle biopsy showed. His muscle biopsy shows hardly any inflammation. So there are no inflammatory cells anywhere, but he has just rapid and severe breakdown of muscle fibers. So there are necrotic fibers all over. So normally there should be a healthier green, but this is all pale. There should be a healthier pink. The entire fascicle was necrosed. There was something just killing off his muscle fibers in there. A lot of these were regenerating fibers, so like for instance this one. And whatever little inflammatory cell you see are macrophages which have come to clean out the debris. Okay, remember macrophages are scavengers. They come out and they clean out the debris out here. So this is what we would have called as necrotizing myopathy. The definition of necrotizing myopathy is you have overabundance of necrotic fibers with little or no inflammation. Okay, and that's what he has. He has an acute necrotizing myopathy. And again, you can see the NADH shows a number of immature fibers. There's hardly any T cell inflammation. There's some macrophagic inflammation in there. There was a recent workshop. The paper is just coming out on the pathological definition of necrotizing myopathy. But when we published this data about 2000, we used, at least in our paper, we used a criteria of more than 25% of your fibers being necrotic, but it's a very loose definition still to this date. Typically, it's associated with malignancy. We reported 4 cases in adenocarcinoma. It's known to happen in some of the myositis specific antibodies. And then the latest and the greatest target for causing necrotizing myopathy are the statins. So less than 1% of patients who take statins can get an autoimmune necrotizing myopathy. Okay, it's less than 1%. We're making statins into a bad drug. Statins are lifesavers, and it really upsets me that when people badmouth statins, it's a very, very, very rare disease. Okay, but it's a very treatable and very devastating disease when you have statin-related necrotizing myopathy. So as I said, the concept of necrotizing myopathy came out in 2004, as established as 2004, but the association with statin causing an inflammatory myopathy first came out in 2010 from this paper by Dr. Amato and John Katz's group, where you can see that there are a number of fibers. So this fiber, this small fiber here, this fiber here, there are a number of these necrotic fibers without any clear inflammation. And this patient had been taking statins, and there was when you took him off the statins and treated him with IVIG, these patients got better. So the concept that in some patients with statin use, you get a treatable autoimmune myopathy first came into existence in 2010. And then this had been reported earlier as well. So necrotizing myopathy in relation to SRP, which is one of the myositis-specific antibodies, had been published in 2002 by Tim Miller and Alan Pestronk. This is, again, a myopathy which is very severe. It's seasonal. These patients typically don't respond early, but you have to treat them for a very long period before they respond. And they have just massive numbers of necrotic fibers. You can see complement deposition in these fibers as well. So here's a fiber with complement deposition there. And Alan Pestronk and I had reported JO1 myopathology back in 2000, and we had shown that there is a fair number of necrotic fibers there as well. And actually that's been validated by other groups as well. So the difference between Dermato and JO1 is JO1 has periphysicular necrosis, whereas Dermato has periphysicular atrophy with no necrosis. They both have periphysicular changes, but there are differences in what the pathology is in that sense. So that I've shown you three cases where they would have been diagnosed with polymyositis. They turn out not to be polymyositis. And the real question is, how rare is polymyositis? And are there ways you can do pathology? Are there ways that you can use your serological markers to make a distinction there? So this issue has been addressed. In 2003, Van der Meulen from the Amsterdam group published this paper. They followed 165 patients who had been diagnosed polymyositis over about a 10-year period, and they followed them long term. And they said what other diseases they would have had. And it turns out that majority of their patients in the end turned out to have either inclusion body myositis, overlap myositis, or even dermatomyositis. And that. So as I said, 76% of their original 165 patients would have met the criteria for definite or probable PM on the Bohan and Peter criteria. But at the end of the follow-up period, only 4 out of 165 patients remained with a diagnosis of polymyositis on that. This was again looked at, and that, by the way, that paper was responsible for that editorial by Tony Amato about unicorns and dragons. Joseph Grau's group in Barcelona looked at this as well, and what they did was that they followed their 36 patients with a pathological diagnosis of PM and followed them long term, and in the end, very few of them had polymyositis, and this table actually shows you that. So patients who had PM, when you reevaluated them, they either had IBM, they had necrotizing myopathy, IBM, Sjogren's disease, and necrotizing autoimmune myopathy. Only one patient had polymyositis at the end of it. And this is the pie chart distribution of everything else other than polymyositis. Polymyositis accounts for 2% of their 36 patients. So are there pathological differentiators? Can you look at the pathology and say, aha, this is IBM, even though it looks like polymyositis? And as you know, pathologically, the T cell inflammation is similar in the two diseases. You still get endomysial inflammation in polymyositis and IBM. You have to have what Engel described as muscle fiber invasion of non-necrotic fibers. That was a hallmark of polymyositis, but you see it in IBM as well. The only difference is rim vacuole. So if the pathologist doesn't see a rim vacuole, they call it IBM, but it may not be IBM. So what Marianne de Wezer, who's in Amsterdam now, did was that she went back and looked at all of her patients who had muscle fiber invasion of non-necrotic fibers on muscle pathology. And I'm going to take you through this slide because it's a little complicated. But the gist of it is when you do a long-term follow-up of these patients who have muscle fiber invasion of non-necrotic fibers, which is supposed to be the hallmark of polymyositis, majority of them developed dysphagia on follow-up. Majority of them developed asymmetric weakness, okay? And they all look like IBM at the end of it, okay? So in what Marianne is suggesting is that if you see muscle fiber invasion, don't think polymyositis, think IBM, okay? The problem is women tend to have more of these features. They don't have the rim vacuoles, they don't have the dysphagia, and they get diagnosed often on that. And then Stephen Brady, who's a PhD student with David Hilton Jones, did a retrospective analysis, and I'm going to leave you with this note. So it turns out that if you have a muscle biopsy that shows rimmed vacuole versus no rimmed vacuole, if you take either the cytochrome oxidase stain or the P62 stain, which is a specific immunostain, you can really increase your sensitivity and specificity. So if you take patients who don't have any rimmed vacuoles on muscle biopsy, and if you take cytochrome oxidase here, if they have cytochrome oxidase negative fibers, your sensitivity is 93%, your 78%, your specificity is 91%. If you have rimmed vacuoles on the muscle biopsy, you still have pretty good sensitivity of 86% and 86% specificity. And if you use the P62 aggregates, your sensitivity and specificity goes really high up. And based on this, they proposed this algorithm that if you suspect IBM, and especially they have inflammatory fibers on their biopsy, use cytochrome oxidase, use P62 staining, you can really improve your sensitivity and specificity. And a lot of our pathologists don't routinely do this, and that's something that needs to be done. And then the only other antibody that I will talk about is the antibody that Andrew Mammon described. What Andy did was that he looked at all his patients with statin-related inflammatory myopathy. He took their blood, he ran it on a gel, and showed that they had antibody that reacted to 100 kilodalton and 200 kilodalton protein. He characterized it further, and it turns out that this antibody reacts to HMGCR, which is the enzyme substrate for the statins. Okay, and there's no doubt that these patients are developing an antibody to the enzyme that statin acts on. Okay, the problem with that theory was that the HMGCR is intracellular, it's actually on the nuclear membrane, and then how do you develop an antibody response to a immunologically privileged antigen? And the answer is actually quite simple, is that all of us go through muscle exercise related injury. Okay, and when you go to the gym, you are sore because your muscles are breaking down and you have injured the muscle. If you do an MRI, the muscle lights up. And when you damage the muscle, your inner antigens now get exposed to the environment. And if you have the right susceptibility, and it turns out in this case is HLA-DR1, so if you happen to be an HLA-DR1 carrier and you have this possibility, then you develop an autoimmune response to it and you develop antibodies. And once you develop an antibodies, it's a self-perpetuating vicious cycle. Okay, the more you give statin, the more HMGCR is now going to be expressed on the cell membrane, and your antibody reaction will keep getting worse. So this is the only time I will not give statins to a patient. If they have a documented HMGCR antibody, I will not give them statins. So I hope I have convinced you that the time has come to abandon the Peter and Bohan and Peter criteria. It's not adequate for that. Polymyositis, I hope I have convinced you, is exceedingly rare. And most cases of polymyositis, if you carefully look at their pathology, if you carefully look at their exam, or if you follow them long term, will turn out to be something other than polymyositis. And I, in a very cynical, skeptical way, tell my fellows and teach my residents that if you see a patient with a diagnosis of polymyositis after the age of 45, they probably have IBM, because IBM is so much more common on that. And they probably also can have necrotizing autoimmune myopathy. I think it's important to think of these diseases in terms of their pathogenetic mechanism rather than their phenotype. And there are a number of classifications being proposed by experts now that uses a combination of pathology findings, serological findings, as well as some of the other phenotypic features to make a more universal classification of inflammatory myopathies. HMG reductase and HMG-CR antibodies and anti-5C1a antibodies have become incredibly important in the day-to-day management of these patients, because not only can you make a diagnosis based on this, but you can actually use them for prognosis, as is true for some of the dermatospecific antibodies as well. And that, if you see anti-5C1a antibodies in a patient with muscle weakness, it is quite specific for IBM. And at some point in the future, we may not have to do muscle biopsies if you use these antibodies, but I don't think the time is there yet. And what Andy Engel and Kichi Arahata had described as a pathognomonic pathology feature of polymyositis, which is muscle fiber invasion of non-necrotic fibers, may not be polymyositis after all. It may be actually a predictor of IBM. And you can enhance your diagnosis of IBM by using special stains like cytochrome oxidase or P62. And as much as I like to make fun of rheumatology and claim that they are from a different planet, actually that's not my word. That's Lisa Christopher Stein, who's a rheumatologist at Hopkins, and she runs a large myositis center with Andy Mammon. I think that we probably should work with our rheumatologists. Okay, and we've tried that at our institution. We've tried, and there are a few of us neurologists who are part of rheumatology groups like IMAX and other groups as well. And I think, so we run a combined myositis clinic about 4 times a year. It's incredibly helpful experience because we bring the rheumatology fellows, we bring our neuromuscular fellows, they bring the tough cases, we bring the tough cases, and we help out the patient, but we help out each other by teaching new things. So I get to learn how to examine the joints, they get to learn how to properly examine the finger flexors. And I think it's a very productive thing. So I think even though we may be from different planets, we should probably try to work together on that. And I'm going to leave you with this beautiful picture of the Alhambra from last year's World Muscle Society meeting that I was lucky enough to go to. If you haven't been to south of Spain, I would highly recommend that. It's an absolutely gorgeous place. Thank you. Any questions or comments?
So you mentioned not basing diagnosis so much on phenotype, but the findings of finger flexor